Thanks for the introduction, Kate, and for getting us started. I'm really excited about the team we have today. We're going to get right into the didactic portion of the presentation, and Kate's going to keep me on time. Thanks to the BCCSU medical writing team for this, and we'll go straight to our learning objectives. Today we're going to outline characteristics of pharmacotherapies for opioid use disorder. I might abbreviate it to OUD, and evaluate whether a potential transition is appropriate for a given client. We'll describe how to safely and effectively transition a person between partial agonists, buprenorphine naloxone, and full agonists, methadone or slow-release oral morphine, and also describe how to safely and effectively transition an individual between full agonists, so the methadone and slow-release oral morphine transitions. A reminder that opioid agonist treatment, or OAT, is the gold standard for OUD treatment. And in BC, we have 3 covered oral OAT options: buprenorphine naloxone, which is known as Suboxone, but I will be using the non-brand name, methadone, and slow-release oral morphine. This session today is discussing transitions between these oral OAT medications, so we won't be talking about some of the other types of OAT that we do know about in BC. And a reminder that details on this transition as well as prescribing can be found in a guideline for the clinical management of OUD, which was updated in late 2023. So the key point today is that shared decision-making is key when transitioning individuals between oral OAT medications. So a rationale for the transition coming from both the patient and/or the provider should be collaborative. Discussion of the potential risks and benefits of all the medication options should be had with the person receiving care. And consideration for implications if the transition doesn't go as planned or isn't considered successful, or the alternative OAT doesn't actually meet that person's needs. So thinking about your plan B and your plan C. Clear explanation to the individual regarding the difference in formulation that they'll be transitioning to and what to expect, particularly at their pharmacy. And then communication with that pharmacy team. So contacting the person's pharmacy to discuss the switch or the transitional prescribing to ensure that the pharmacy is aware of the plan and also is able to fill the new prescription. Once the decision to transition is made, we should be recording the clinical rationale and the person's consent in the medical records, including the discussion as described above. So what are some clinical indications for transitioning? Clinicians might approach transitions with their clients by gauging how their current treatment plan is working for them, what's going well, what are some challenges, and conversations can be framed as adjusting medications to better suit client needs, if applicable, and to ensure that clients feel supported and that they're actively making this choice, which also means that the client or patient themselves might actually come to you as their provider, describing a need or desire to discuss transition themselves. There are many reasons or circumstances that might merit a discussion from the provider lens, including there's been no change from pre-treatment levels of unregulated opioid use, if that was one of the patient's goals in terms of starting OAT, or if there's been increased or reinitiated use of unregulated opioids to manage cravings or withdrawal while on their current OAT. Potentially if there's continued or increased use of other substances for cravings or withdrawal. So a reminder that people may respond differently to different OAT options. So a person who's on buprenorphine naloxone might be continuing to rely on unregulated opioids, and that's an avenue for discussion of alternative full agonist OAT potentially. Again, if the patient themselves reports that withdrawal and cravings are not adequately addressed, another good reason to discuss transition. This should all happen within the context, of course, of also addressing the actual dose of the current OAT that a patient is on. Another reason is that patients themselves might desire simpler or more flexible treatment. For example, take-home doses, which are often more frequent with buprenorphine naloxone, or factors that impact the health, quality of life, or risk or harm to the person. So availability concerns in certain communities of particular OAT, or a person might have a new diagnosis, a new medical diagnosis that actually makes their current OAT contraindicated or riskier than previously, which would mean a conversation about their current medication and alternatives. And finally, reducing negative side effects from current medications. So we do know that buprenorphine naloxone has fewer side effects than other OAT medications. And if patients are noticing sedation or constipation with a full agonist, there's an avenue as well for discussion of transition. So considerations for individual factors, we have covered a number of these, but just to emphasize again that the treatment plan should be considered in the context of the individual circumstances. So it's collaborative work in terms of the patient's treatment goals, their preferences, their life circumstances. Really be sure to understand and offer appropriate support, psychosocial, as well as medical, that people might need during the transition. Ensure that their concerns are heard and validated, and ensure that the person actually understands and agrees with the treatment plan, as well as backup plans, your plan B and your plan C. So when it comes to this treatment planning, it is important to, again, involve the pharmacy as part of this patient's care team. So to confirm availability of the OAT medication you're switching to, make sure that both the patient and pharmacy are aware if you are going to be prescribing a transition where 2 OAT medications are prescribed on the same day and both dispensed on the same day, and includes medication-specific dispensing instructions, such as blister packing of buprenorphine naloxone doses or something like that. Make sure there's a clear plan with your patient and the pharmacy for missed doses, and maybe remind your pharmacy to monitor that individual that they're seeing daily for any clinical changes or side effects that they've noticed. And of course, make sure that your previous prescription has been canceled. So what do transition protocols look like? We're going to review in this presentation protocols that are based on clinical experience and expert consensus. But note that there is a lack of evidence-based protocols for transitions between OUD medications. There is developing evidence on low-dose induction protocols for transitioning from methadone to buprenorphine naloxone. And the goal of the transition process is to safely titrate and transition to a new medication so that a patient feels comfortable and isn't experiencing withdrawal symptoms between doses. If prescribers in BC are uncertain about transitions, we do recommend consulting either with the 24/7 addiction medicine support line or their local addiction medicine specialist services or clinics. So a reminder of the oral OAT pharmacodynamics in terms of the agents we have available in British Columbia. So our 3 oral OAT medications are buprenorphine naloxone, which is a partial mu opioid agonist, which has a very high affinity at the mu receptor. Due to its partial properties, buprenorphine has a sealing effect, which is protective against drug poisoning, but it also displaces full agonists from those opioid receptors, which may cause precipitated withdrawal if therapeutic doses are taken at the same time as full agonists. Methadone and slow-release oral morphine are full agonists that have higher activity at the opioid receptor than buprenorphine, which can cause more sedation and respiratory depression than buprenorphine. There is, however, no risk of precipitated withdrawal from full agonists. So let's talk about these transitions. So transitioning from buprenorphine naloxone to methadone or SROM is actually relatively uncomplicated because, again, methadone and SROM are full agonists while buprenorphine is a partial agonist. It may be initially uncomfortable for the person as buprenorphine naloxone is discontinued and the full agonist is titrated, but again, there's no risk of precipitated withdrawal during this transition. So here's an example of what this might look like. On the first day of transition, the patient takes their regular buprenorphine naloxone dose, and then on the second day, we initiate the first dose of methadone or SROM within 24 hours of that last dose of buprenorphine naloxone. There are titration protocols as examples within the guideline for the clinical management of OUD that was updated in 2023. Now, choosing that starting dose of methadone and SROM does depend on a number of factors, such as known opioid tolerance, current opioid use, co-occurring substance use, comorbidities, and potentially other medications that patient is relying on. We still describe a methadone starting dose as some range between 5 to 40 milligrams daily based on these factors. But clinical experience and emerging guidance does suggest that a starting dose of up to 40 milligrams for individuals who use fentanyl and have established tolerance to methadone based on past treatment history is safe. You then have to titrate your methadone, which again, we do usually every 3 to 5 days at dose ranges of 5 to 10 milligrams, again, taking in the clinical realities of the patient in front of you. And a reminder that doses should be increased more cautiously for people with lower or unknown tolerance. So here's an example of buprenorphine naloxone transitioning to methadone. On day 1, your patient has taken their last buprenorphine naloxone dose. And then the next day, you initiate methadone at a starting dose of 40 milligrams with ongoing titration, 10 milligrams increase 3 days later. And then that titration can be continued per your patient's needs. I think we have an example of an SROM titration, but not quite yet. No, we don't have that. So I will just say that if we go back to that methadone slide, the same method could be used to transition someone from buprenorphine naloxone to SROM. And there would be using dose increases of titration of up to 100 milligrams every 24 to 48 hours. But those increases should be separated by at least 24 hours. So what about going from your full agonist, methadone or SROM, to buprenorphine naloxone? So low dose induction is the preferred method for this transition because it reduces the risk of precipitated withdrawal and does not require a washout period of the patient's full agonist medication. It does, however, have an extended length of time to reach a therapeutic dose, and ongoing titration is likely required. It requires a lot of follow-up to assess how the titration is going, and the speed of this transition can be modified for the person in front of you based on their symptomatology. A traditional buprenorphine naloxone induction would require cessation of your full agonist, so methadone or SROM, which may destabilize a person who's otherwise stable on those medications, as well as cause precipitated withdrawal, depending on how that traditional induction goes. So a low dose induction maintains an individual's dose of their full agonist while gradually increasing the buprenorphine naloxone dose, which allows it to slowly accumulate at the mu opioid receptors over time, gradually displacing the full agonist. Again, a goal of not having any precipitated withdrawal. The full agonist can then be completely stopped when the target buprenorphine naloxone dose is reached. And again, there are more details regarding this in the 2023 guidelines for clinical management of OUD. Here's an example of what this low-dose induction would look like. So your full agonist might be SROM or methadone, and as you can see, you continue that at the patient's current prescribed dose while you initiate BID to TID low-dose buprenorphine naloxone. That dose increases daily, and here we have an example of a 7-day induction where the target dose of buprenorphine naloxone of 12 milligrams is reached at day 7. On that day 7, the full agonist can be completely stopped. So the last dose is taken the day before. And note that a 5 to 7 day titration protocol may be challenging for people on higher doses of full agonists, particularly methadone. And in such cases, a slower transition protocol where you stretch out that transition to 12 milligrams can be considered. Now, the simple transitions that just involve some math. Sorry, no math yet. We're between methadone formulations. So just a reminder that in British Columbia, we have methadose and Metadol D, which are covered as regular benefits. And there is no dose change needed when transitioning between formulations. We can also access compounded methadone and methadose sugar-free, which do require special authority and trials of the other two medications, methadose or Metadol D, before a client can access these. I will also clinically remind people that if you're going to go for compounded methadone or sugar-free, please ensure that your pharmacy is able to stock and maintain that for your patient. But again, transitions between methadone formulations do not require dose changes. Now we have a little bit of math. So from your full agonist, SROM to methadone, this can sometimes be challenging due to different pharmacokinetics. We practice with a ratio of somewhere between 12 to 1 or 10 to 1 SROM to methadone, again, depending somewhat on patient factors, their current doses, as well as, to be honest, provider comfort or patient follow-up capacity. So what we're trying to do here is avoid inadvertent methadone toxicity because pharmacokinetics are quite different, both in terms of half-lives as well as deposition in body fat and liver metabolism. So frequent reassessment during these transitions are important, either virtually by phone or in person if possible. And a reminder that full agonists should be daily witnessed during titration. So for patients who'd had take-home doses, it is critical they understand that during the transition period for close monitoring, daily witnessed ingestion is expected. We have an example here of what this transition looks like. And so this patient is currently on an SROM dose of 1,000 milligrams, and we're going to transition to methadone using a 12-to-1 ratio. So we're going to reduce the initial SROM dose by 12 times the starting methadone dose. So that's 40 times 12, which is 480, which means that on their first day of methadone 40, a SROM dose of 520 should be given. What you're then doing is titrating the methadone per usual protocols, which is every 3 to 5 days, and reducing your SROM by the increase in your methadone dose. So if you're increasing methadone by 10 milligrams, you multiply that by 12, you get 120, and you reduce your SROM by that amount. Essentially, this cross titration continues until your SROM is discontinued, and then you can continue titrating your single agent methadone. So when we're doing these types of transitions with the cross tapers, they do occur over a longer period of time. We're seeing the SROM gradually discontinued as methadone is increased. We do recommend slower titrations for individuals who may be at higher risk of opioid toxicity, so potentially a recent loss of tolerance, such as recent discharge from withdrawal management, residential treatment, or correctional facilities where they may not have been receiving OAT or unregulated substances. In patients who have severe respiratory illness or decompensated liver disease, as well as patients who are using high amounts of alcohol, other types of sedatives or benzodiazepines, or prescribed medications that affect methadone metabolism, which is essentially medications that use the cytochrome P450 pathway in the liver. We also exercise caution in patients over the age of 55 and those with no methadone experience. So if we don't go slowly, we go rapidly. So what does a quick transition look like? We don't consider this appropriate for patients who've never had methadone experience. And it is important to closely monitor individuals during this time. Again, we use the same ratio of 10 or 12 to 1. And we have an example of it here. Starting dose of 1,200 milligrams of SROM, we'll use the 12-to-1 ratio, and essentially we convert that 1,200 milligrams to 100 milligrams of methadone using that dose. Titration can then be continued per usual guidelines every 3 to 5 days. Going the other way from methadone to SROM, our ratio is slightly different. And again, cross titration in which there's no washout period required is recommended using a conservative ratio if clinically indicated. Gradual transitions are suitable for people who are not using unregulated opioids and are already stabilized on their dose but have a reason for transitioning. And also for people who have the ability to take the time to do a transitional period. Again, there's no washout period required, and we do recommend fairly frequent assessments to see how this transition is going. A reminder again that full agonists would be daily witnessed during this titration. And here's an example of what this might look like. So this is someone who's on 150 milligrams of methadone transitioning to SROM, and we'll use a 1:6 ratio of methadone to SROM. So their stable methadone dose is 150 milligrams. And what we're going to do is multiply by 1.6 to get a target SROM dose of 900 as the equivalent of that 150 of methadone. We'll do a slow transition where we drop the methadone dose by 100, replacing that with 6 times that SROM dose, so 600 milligrams, while continuing the 50 milligrams of methadone. That can continue for a period of days, again, based on clinical factors. And then that methadone can be stopped if you drop 50 milligrams and then multiply again to complete your SROM titration to 900 milligrams. Again, you can continue titrating the SROM to patients' need beyond this point every 24 to 48 hours. Now, what might a rapid transition look like going from methadone to SROM? Here we'll use the 1:8 ratio, someone who's on 100 milligrams of methadone, and we just are going to transition the next day to 800 milligrams of SROM. Again, continuing titrations. A reminder that if you're doing a rapid transition, you might want to do a slight dose reduction by 20 to 30% of that SROM because of incomplete cross-tolerance between methadone and SROM. Now, rapid transitions, again, may be appropriate for people who are using unregulated opioids or are unstable on their methadone dose, or have experienced side effects or developed contraindications to methadone, or prefer to make this transition quickly for whatever patient-centered reason. So we've gotten through the end of the didactic portion, and I will just remind everyone that, again, we consider transitioning OAT options to improve adherence for a patient, reduce side effects, enhance their flexibility and quality of life, or meet their goals in terms of unregulated opioid use or cessation of use. These decisions should be collaborative. They should reflect the person's needs, preferences, and circumstances in front of you. And we should ensure as prescribers that we're working with pharmacies as well as the person in front of us to make a treatment plan that's feasible, safe, effective, meets their needs, and has a backup plan. A reminder that our protocols for transitioning between OAT are based on clinical experience and expert consensus, and that in British Columbia, we are lucky to have a number of experts who can be consulted for additional support that may be needed during transitions. Again, in terms of resources, this slide deck does come from the guideline for the clinical management of OUD, and that there's online education available to all of us through the Provincial Opioid Addiction Treatment Support Program, linked there. I'm going to hand over now to Kate to continue our session.